Our last speaker is Dr. Greg Robertson. He's a gynecological oncologist who's worked at the Royal Hospital for Women and St George Hospital for 25 years. And he conducts clinics in Canberra as well as here. And he's a past chief examiner for the Royal Australian College of Obstetricians and Gynecologists in gynecological oncology, and also involved with the RAF as wing commander in the reserves.
Thank you very much for the opportunity to speak, and enjoy your Saturday afternoon. I'm a direct contrast to the fabulous talks that you've just heard, so this is more the pointy end of the stick in terms of what we almost do now on a day-to-day basis. But it certainly is an epidemic that we are, and which one of these do I push? Yep. And as already has been discussed, that whilst endometrial cancers are certainly an area that's growth related to obesity, there are also other areas in the body which have been noted to be due to the obesity epidemic. Now, when you look at the incidence of gynecological cancers in women, and this is in 2017, you can see that uterine cancer takes a lion's share with about 45%. And as has already been pointed out, things like cervix cancer, whereas once I was doing probably 2 radical hysterectomies a week for cervix cancer, now it's quite a rarity, and very once every 2 months, which is a tribute to the screening program, particularly through the GPs. And obesity has certainly increased, and the incidence we're experiencing. And if you looked at the rates, you can see how that since 1982, it very much mirrors the other speakers' presentations, where there's an increase in the obesity rate and also an increase in the rate of endometrial carcinoma. So, having had lunch, you can see here that this is a uterus, cervix is down here, and this is all the myometrium. So it begins within the endometrium alone. And the risk of spread is really related to what kind of cancer it is. Generally in the obese, it tends to be a more well-differentiated, slower growing tumour, and the depth of invasion is also another marker for risk of spread to the lymph nodes. And so when you have a uterus like this, you've got a very high risk of spread to the lymphatics. So what drives it from being a healthy endometrium through to either the precursor for malignancy, which is complex atypical hyperplasia, and then finally an endometrial carcinoma. And this is very much related to that, either the increase in estrogen. The estrogen produced by fat is quite a weak one, it's estrone. But if you have enough of anything, eventually it's thought to promote it. But more recently, I think the contribution of insulin and insulin growth factor is probably a greater thing as well as the kinds. And equally, the way of reversing it is through diet. And certainly when patients who are trying to retain fertility, having developed an endometrial carcinoma, there's no question that weight control and exercise make a huge contribution, as well as other factors in reversing the process. So it is reversible. So how do we manage these women? Firstly, at the initial consultation, it's that teachable moment. It's that point where you can actually point out that obesity is a risk factor. And it's very interesting. I had a community nurse yesterday who weighs 110 clicks. So, registered nurse, and she says, what's caused it? And I was rather stunned that she even asked the question. But in the general public, and even our trained public, they still don't appreciate that obesity is a prime mover for most of these cancers. What's changed for us is how we deal with them. When I first started, we were mostly doing these cases through laparotomies, and as you can imagine, all the complications you have when you're cutting through 5-10 inches of fat, and wound infections are predominant. Minimally invasive surgery makes a huge difference And certainly our anaesthetic friends as well have made a stellar improvement in their survival and general ability to withstand surgery, because the difficulties of operating on somebody, remembering that all our bits are down the bottom. I'm going to come back in life as an ophthalmologist. I think that's going to be the only way of getting around this problem. So it makes it extremely difficult. So it's not only a risk factor for this patient, it's also a risk factor for everybody else around there, the wardsmen, the nurses in the theatres as well as the operating rooms, the surgeons. My wrist is absolutely stuffed. So the move across is now to the robotic, and certainly that for the bigger patients is going to be significant, more because most of the incisions are high rather than having to go through the pannus, which is a real problem. And the other beauty of the laparoscopic approach is that by and large they head home 2 days later, so much less morbidity, much quicker time to go home. So the other dramatic thing that we're also doing as a sideline, as I've mentioned, that these cancers tend to metastasize first to the pelvic lymph nodes, and you get a lot of power by knowing whether or not there's any spread. So similar to what happens with breast cancer, where you do sentinel node estimations of breast cancer, we're now doing that in some centres with endometrial cancers using ICG, indocyanine green, which we pinched off the cardiologists. They've been doing it for 20 years, but we stole it from them. So by injecting some ICG using a laser, so this is the external iliac artery, internal iliac, and you see the lymph glands in there, and with a laser it highlights the lymph gland that is first draining, and just by taking that it reduces significantly the morbidity associated with lymphadenectomy for the patients, and having caused some women to have severe lymphedema, I'm very grateful for these kinds of procedures. Also becoming more important for us is the management of women who are wishing to retain their fertility, as we tend to be a society that defers fertility, and their obesity and risk of endometrial cancer increases. Increasingly, we're seeing lots of young women who either have pre-malignant, so complex atypical hyperplasia, or even early cancers, wishing to retain their fertility, and using a combination of marinas, high-dose progestogens, but also, as we mentioned, the use of physiotherapists and dietary stimulation to try and get them to lose weight. And that does have a significant impact. They've got about a 60% chance of reversing these problems. I'll touch very briefly on the metformin issue because of I'm sure as we touched on later on, metformin, a drug commonly used in endometrial cancers, and because of its tumour suppressor potential as well, we try and get patients to go onto it if there's any chance we can. So as I said, weight loss and exercise. There was a very interesting paper which showed that by losing 5% of your weight in the normal population, this is from the WHI study, it actually reduced your risk of endometrial cancer by 30%. If you're already obese and lost 5% of your weight, you reduced it by 56%. So weight loss does contribute significantly. And the other thing is, if you're overweight and increase your weight by 5 kilograms or 10 pounds, you actually double your risk of getting endometrial cancer. So weight's very significant. Thank you very much.